Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have our presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime using the chat pod located to the right of your webinar platform. You may also download a copy of today's slides using the Files pod located directly below the slide presentation. It is now my pleasure to turn the conference over to today's first presenter, Chris Hunt. Please go ahead.
Thank you so much. Hi, everybody. Good morning or good afternoon. This is Chris Hunt, Senior Director with the American Hospital Association Center for Health Innovation, and I'm really happy to have you here today for the September 2021 AHA Team Training Monthly Webinar. This month, it's The Hidden Truth About Emotional Exhaustion and COVID from 250,000 Healthcare Voices. Now, what makes this presentation special is that this is an Advancing Care Conference sneak peek. Now, the Advancing Care Conference was supposed to happen October 4th through 6th in Chicago, but given the ongoing impact of COVID-19 and as part of the AHA's continuing efforts to support frontline healthcare professionals, educators, and leaders, we are postponing the inaugural Advancing Care Conference to 2022. So we will be getting you additional details at a new conference date very soon. But as you can understand, we had to postpone this. We really want this conference to be something that occurs in person because it's going to be highly interactive and very much about getting together to solve challenges, and it just is the right decision to move this to 2022. But that being said, our presenters today were scheduled to present in the conference in a couple of weeks, and this was going to be a sneak peek of one of our really cool conference presentations. So, well, let's enjoy it, and then we'll consider it a sneak peek, even though the conference will be sometime in 2022. So, some rules of engagement. You could listen to the audio two different ways. You could do so through your phone. If you do that, mute your computer speakers so you don't get that weird echo, or you could listen through your computer. We find that sometimes people have trouble listening through their computer if they don't have the best internet connection. Sometimes hospitals have bandwidth issues, and if you're coming from a hospital, you might have an issue. So give a call on your phone if that is a problem for you. I'm talking through my phone right now, for example. All hyperlinks are active on the screen or in the chat if you click them, and they'll open up a new window so you can go back and look at stuff later on. And we'll do Q&A at the end. The way we like to do this is drop your question in the chat box that you see on your screen right now, and I'll gather all those questions and try to curate a nice Q&A to have at the end. So that's how we'll go about and do that. Continuing education credit is offered by this webinar. It is 1 CE credit hour. You must have a Duke OneLink account to do that. You only need to do this account once, so you could use it for all future webinars. If you've already done it before, you don't need to do it again. Instructions on how to do this are actually in the Files pod that you see there, and it says Instructions for Webinar CE Credit. And you can text that code to that phone number after 1 p.m. Eastern today. It's open for 24 hours. We'll put that code back on screen at the end and also drop it in chat, so no worries about writing that down right now. Other upcoming team training events, we've got a bunch of webinars coming up that you can see on the screen here. So make sure you register for those if they are things that you're interested in, all about different topics. So, jump in if anything looks good to you. We have a virtual course called Team Steps for Change Leaders and Champions. We're working with our partners at Duke on that course. It's a great 7-week online course. People seem to really like it. And it's really focused in on people who are already working on Team Steps, maybe need a little refresher, but really need to understand how to connect it in to other programs they're already working on at their hospital or health system. So that's what that course is about. Also, please join our online community, Mighty Network, which is a great free platform that you can go in. It's kind of like social media for team training. And so people share stories, tools, content, chat about things. It's a great network. A lot of people are involved with it, and it is really the way to get all the up-to-date information and to connect with your peers. Like I said, I've already talked about the Advancing Care Conference, so I'm not going to spend any more time on that here. Okay, so today's presenters, we have 3 gentlemen with us today. Very excited to have them with us. Our first presenter that I'll be tossing things over to in a second will be Dr. Bryan Sexton, who is the director of the Duke Center for Healthcare Safety and Quality, as well as an associate professor at the Duke University Health System and in the Department of Psychiatry. Dr. Sexton has been really a part of the family for a very long time, and so we're greatly excited to have him here today to be a part of this presentation. We also would like to introduce Joshua Prue, who is the Chief Data Science Officer at Safe and Reliable Healthcare, as well as Dr. Alan Frankel, who is the CEO at Safe and Reliable Healthcare. So these 3 gentlemen were on slate to present for us in person in October, and we're very happy to have them here today and look forward to hearing their presentation. So, Dr. Sexton, tossing things over to you.
Well, thank you, Chris, and thank you all for joining the webinar today. We hope to share some interesting insights of what we've been learning during our global health crisis here. So I'm Bryan Sexton, and I am a psychologist here at Duke. Today, I'm going to talk a little bit about what we've learned about emotional exhaustion during the pandemic and what we've learned about what you can do about emotional exhaustion. And then we're going to hand it over to Josh and to Alan at Safe and Reliable, and who have the world's largest data set on well-being, and it happens to be on healthcare worker well-being. So you'll get to see some pretty cool and interesting insights from there. The data that I'm going to be sharing with you are just a subset of the larger data set that Safe and Reliable have collected. So what can we say about emotional exhaustion real quick off the bat? If I could say one thing that could stick with you today, please stop thinking about well-being as happiness. Well-being, in fact, is not happiness. The shorthand for thinking about well-being, thinking about burnout or work-life balance or emotional exhaustion, the shorthand should be well-being is really your ability to do stuff. So when your well-being takes a hit, your ability to do stuff takes a hit. You're going to see that in your teamwork. You're going to see that in communication breakdowns and in disruptive behaviors and in problems with leadership. Like, your ability to do stuff is your well-being. And if you use that frame of reference as you look at the slides and the data today, it'll all make so much more sense. Well-being is really your ability to do stuff. So let's get the elephant out of the room, out of the way real quick here if we can. What do we know about well-being, and in particular emotional exhaustion, during the COVID-19 pandemic? Well, just so happens that because of our relationship with Safe and Reliable, we have over 50,000 healthcare workers that we've been looking at in both September of 2019, so before the pandemic, and then in September of 2020, which is during the pandemic but before the vaccines. So this was an interesting time to look at a pre and a post. Let's follow a big group of people before and after. What do you think happened in those 2 time periods? Something kind of interesting showed up right away. The distribution in green here is the 2019 distribution. There were over 2,000 work settings, and it shows their emotional exhaustion. The red distribution is the same work settings, but in 2020. And you can see it all shifted up. It didn't shift up 50 or 60 points, but it's shifted up very consistently for all these different work settings. Here's a real question, though. If you put everybody together, that difference between the green, which is pre-COVID, and then the red, which is during COVID, is definitely statistically significant. That's a T of 21. That's pretty big. Anytime a t-test is 2 or greater or -2 or less is going to be a statistically significant one, so that's very significant. However, something interesting unfolds if you begin to look at the differences in emotional exhaustion rates by role. So overall, it's a big difference. But when you look at it by role, you'll see something quite different. Nurses up dramatically, clinical support nurses, aides, they're all up dramatically. There's one group, however, that didn't go up. In fact, they went down, and that's physicians. Now, I'm not talking about physicians working in COVID units and EDs and ICUs. I'm talking about all physicians when you put together, dermatologists and everybody else. Overall, this really big sample of physicians, their burnout, their emotional exhaustion actually went down. Their ability to do stuff actually got a little better on average. Now, I'm not talking about, ICU physicians. I'm just saying on average, physicians, their ability to do stuff got better. While the rest of the healthcare clinical and non-clinical roles, they actually got worse, and especially so for our nursing colleagues. Now, this is not yet published. This is something we are submitting in the next basically 2 weeks. We're pretty excited because this publication is something we were working on for a couple of months. But we did publish something earlier this year showing that the COVID-19 impact on emotional exhaustion for healthcare workers is like the equivalent of going live with 2.5 or 3 EMRs back to back with no break in between. You would never do that. You would never want to do that, and that's pretty much the closest thing we can come to comparing what is happening with our well-being. Now, for those of you who love the teamwork stuff and you want to hear more about that, Kyle Rader at Duke, who's our medical director at our center, is using the same data that I just showed you for emotional exhaustion and is showing an equivalent kind of a decrease in teamwork. It's not as big a decrease or a change as what we saw for burnout in healthcare workers, but teamwork definitely took a hit during the pandemic, and he's working on that right now. He's one of our Team Steps master trainers at Duke. So the bad news is, yes, the pandemic has had an impact. It's been a pretty big one. That's probably not surprising to you at all. But here's the next question. We know it's bad, but can we make it better? Can we cause burnout to be reduced? Can we cause it to go down? And in our lab, we have a $3 million grant from NIH that we've been using for the past 5 years to run randomized controlled trials to show that we can cause burnout to go down, to show that we can cause reductions in emotional exhaustion rates in busy, tired, cranky healthcare workers. And it turns out that decrease using randomized controlled trials, we just published this a couple of weeks ago, that decrease in emotional exhaustion is the equivalent decrease in emotional exhaustion of what you see in terms of the increase because of COVID. So yes, it's worse. Yes, it's bad. If you're looking for statistical significance within your medical center, a 2-point increase in your medical center in your emotional exhaustion scores would be statistically significant. And we're talking about for this 50,000 person data set, it's a 5-point. Or 5.5-point increase. Wow. But we can cause in randomized controlled trials a decrease of over 6 points. So as much as it's gone up, we know we can cause it to go back down. I just want to put that into perspective. So please understand, we deal all the time in mental health arenas with things like depression and things like anxiety. And we know how to treat depression and anxiety. For some reason, people look at burnout and say, oh my gosh, there's nothing we can do about burnout, or only systems fixes for burnout. Well, that's not exactly true. We need to fix the system, and we need to help people who are struggling with burnout. We have to do both of those things simultaneously. And the good news is burnout is not immutable. We can change it. We can treat burnout. We know how to diagnose it. We know how to treat it. We have excellent tools for diagnosing it and for treating it. And they're not all things like, meditation and running marathons and yoga. Or in therapy and coaching. There are things that are simpler that you can do, and that's one of the things that we do are called bite-sized well-being interventions. What are some simple things that you can do that have enduring effects in your well-being? And sometimes we kind of put up a boogeyman for this stuff, and it's not really fair. And a common boogeyman for burnout is the EMR. So the electronic medical record is one of those easy things to punch because it's not usually we don't know a whole lot of people who kind of represent the EMR in our there's a small number of people, and we get to kind of point at them at meetings when everybody's kind of scoffing. But that's really not fair. In fact, we did a study here at Duke of our healthcare workers that use the electronic medical record, mostly physicians, and what we found was that yes. If we do audit logs of like when you log in, how much time you spend in the EMR, how much time you spend in the EMR on nights and weekends, and all these different kinds of audit kind of variables, what we found was that you can predict burnout by looking at the way you use the EMR, but you can predict burnout 10 times more prediction of burnout if you just look at the culture where you work. What's the teamwork like? What's the leadership like? What's the burnout like where you work? And those norms, those cultural norms make such a big difference. So tenfold bigger difference than the EMR, which is such a convenient target. So here's a great question. What if there was a metric? What if there's a variable that was so potent that it predicted clinical outcomes and operational outcomes and safety culture and well-being? It predicted all those things. What if there was a ruler, a metric that was that powerful? And what if I told you that it predicted, the burnout of your colleagues, your leadership, your teamwork norms, your patient safety norms, your work-life balance norms, your quality improvement readiness, your capacity to take on new QI interventions, your ability to thrive at work, and your ability to bounce back and recover from problems at work? What if I told you that one variable that predicts all those things, all those cultural and well-being variables, is actually your personal burnout, your personal emotional exhaustion, which is, as we said before, your ability to do stuff? It predicts all those cultural variables and well-being variables. It is, if it's the one ring to rule them all, it is the one variable that is just so very powerful. We do this at Duke. One of the things that we measure in our data is we look at things like turnover and preventable harm, and we just published this with Carrie Adair and Kyle Rader, who's our medical director, showing that you can predict turnover at Duke using our emotional exhaustion data. You can also predict preventable medication-related SRS reports, so incident-reported harm. We can predict preventable harm, and we can predict turnover using things like work-life balance and things like emotional exhaustion or personal burnout. What's really interesting here is that when we put our ability to predict, that's what you see here on the right, predict turnover and predict preventable harm, we can look at emotional exhaustion, we can look at work-life balance. They predict. But the NS that you see here on the right-hand side, next to turnover and preventable harm, that NS stands for not statistically significant. So you know what does not predict turnover or preventable harm? Your Press-Ganey data does not predict that stuff. So let's be careful about the metrics that we use and make sure that they are valid and that they predict important things and that they are responsive to interventions and show changes in response to kind of global events. Let me go one further and just show you one more fun piece of data that we collected in a statewide sample using SCORE survey data across the state of Michigan. This is pretty big data set, 31 hospitals. It's over 800 work settings in the state of Michigan. And what we found when we measured leadership in the state of Michigan, something really interesting. We measured leadership by saying, in my work setting, the leaders are available at predictable times. They provide frequent and useful feedback. And in particular, this red one here, our leaders regularly make time to provide positive feedback to me about how I'm doing. That one item was a big driver of, you guessed it, burnout. For every 10-point increase in leadership measured using these items, right, we saw a 3-fold reduction in the odds of burnout for that respondent. So the way we view leaders and the way that we view burnout are yoked in a very powerful and potent way. So the actions of our leaders make a big difference, especially right now, especially when the world is on fire. I'll give you a couple more fun examples. A few years ago, together with our friends at Safe and Reliable Healthcare, we published it was a feature article at BMJ Quality and Safety, an article on senior leader walk-rounds. And, the traditional walk-around, phraseology is, how are we going to harm the next patient around here, and what can we do to prevent it? And that was a great way to start a conversation in a busy unit in 1999. In 2021, if you say, how are we going to harm the next patient, you'll get some pretty angry glances from folks. And so we use a different framework. We call it positive rounding, where we say, can you please share 3 things that are going well around here and 1 thing that could be better? And that framework creates psychological safety with the staff and allows them to talk about what they're hopeful about and what they're grateful for and what they're inspired by. And then they can talk about the pebble in their shoe. And that psychological safety creates a better dynamic with the leader. It creates more follow-through. It's a pretty interesting way of modifying traditional safety walk-rounds into positive rounding. Now, I'll also say real quickly here that in the past few weeks, the world has been on fire to a particularly kind of heavy extent, and we know that asking people, tell me what's going well, when you're overrun with people who refuse to take a vaccine or wear a mask, and that can be really hard on a lot of us. Very, very hard. Just in these past few weeks has been some of the most difficult weeks for many of us in healthcare. And so we've actually started at Duke not just positive rounding, but crisis rounding, and just checking with people to make sure that they're doing okay, and being present. That physical presence is so important right now. But we did collect these data and we published them, and the Joint Commission actually did a press release on it, showing that positive walk rounds were effective in terms of predicting not just safety culture, but well-being of the workforce. So let me show you what we found there. Here's the press release from the Joint Commission. They're pretty tickled about this. If you look across, this is Duke University Health System. This is 400 plus work settings, and what you're looking at are all these 400 bars. It's the percent of people in each work setting who said yes. Senior leaders ask about what's going well in my work setting. So it's the percent yes. And in the left-hand side here, you'll see that the fourth quartile, we don't ask very much about how people are doing. And on the right-hand side, the first quartile, we do ask about kind of how people are doing. And there's a pretty big difference between the first and the fourth quartile in terms of our safety culture and well-being, improvement readiness, local leadership, our teamwork. Can we speak up, resolve conflicts, good position nurse dynamics, our safety climate. Our emotional exhaustion is the reverse pattern. See how that's going down? When we do ask about what's going well, there's less burnout, there's less emotional exhaustion. The burnout climate is lower, so my colleagues are less crispy when we're asking about what's going well, and work-life balance is better in those units where people are asking about what's going well. So there is a pretty interesting pattern here where if you show support, if you are physically present and you show support and you're creating that psychological safety, it makes a big difference for the folks at the front lines of care delivery. We showed a similar pattern, just to give you an example, for institutional support for second victims. When you are showing support for your second victims, and here's the same thing that we showed you before, here's another publication, just showing the different quartiles of kind of how people will say, yes, I feel supported by my institution. There are big differences, again, in all those safety culture and well-being metrics: improvement readiness, local leadership, teamwork, safety climate, burnout climate, and work-life balance. Pretty interesting stuff. So your presence makes a difference as a leader, and the way you interact with people and show support makes a difference as a leader. But before we hand it off to Josh here in just a second, I wanted to show you one more fun thing that we just put in the literature on some of the demographic breakdowns. But first, I just want to kind of conclude my summary of what we're learning about safety culture and well-being. We know that this survey that we're talking about, the SCORE survey where we collected all this data, is psychometrically very robust. There's no other instrument that really touches it in terms of psychometrics, at least not yet. We know that incorporating workforce well-being into your assessments of safety culture really gives leaders an extra layer of diagnosticity and things that they can act on, especially right now. To not ask about well-being right now is a real mistake in your work settings. And then it predicts both clinical and operational outcomes, but we've linked it to leader walk-rounds, positive walk-rounds, second victim support, preventable harm, turnover, and disruptive behaviors. But there's one more thing we've linked it to, and that's respondent demographics. So let's talk about that real quick. I want to share with you what did we learn about some of the boy-girl differences. We just published this a few months ago in JAMA Network Open, a big sample with some world-class leaders in this at Mayo Clinic and at Stanford that we worked with to kind of put our measures of work-life balance into these national samples of physicians. And in this particular study, where we looked at work-life balance and differences with work-life balance amongst U.S. physicians, it was a sample of over 4,000 U.S. physicians. And what we looked at there was things like, were there gender differences within specialties in their work-life balance? Were there differences in terms of the hours worked per week, et cetera, et cetera? And what we found was there were 4 specialties in particular where the gender differences were particularly pronounced, and that was in psychiatry, emergency medicine, general pediatrics, and anesthesiology. Those were the places where within the specialty there were the biggest disconnects between the male and the female physician respondents. But more to the point, perhaps not surprising, hours worked per week. As your hours worked per week go up, your work-life balance goes down. That's the same for boys and for girls. As you get older, what's interesting is that it looks like the females, which are the orange bars here on the bottom, the females get smarter as they get older, which is a nice one. And then also the age of your youngest child. So before you have children, there's no difference in work-life balance between male and female physicians. But as you have your first child, and then as that child gets older, the discrepancy, the disconnect between the male and female physicians gets broader, even after that child leaves the house. So after that child is 23 years old or older and living outside the home, the female physicians are spending more time in the EMR. They're spending more time doing household chores. So there are some interesting gender differences. I will share with you, it's important to look at race and ethnicity and gender with these things, because one of the lessons learned for me in this particular publication was that the one demographic group that had the best work-life balance of all the physicians were African-American male physicians. And the one group that had the worst work-life balance of all the physicians was African-American female physicians. They kind of defined the ends of the continuum for work-life balance. So it is important to look at gender. It is important to look at these demographics and understand where there's more vulnerability and less vulnerability, because your work-life balance today is a fantastic predictor of what your emotional exhaustion is going to look like tomorrow. That is a really good canary in the mine for kind of where things are going. So with that, I did want to hand it off to Josh, and we'll have some time hopefully at the end to do a little bit more Q&A, but I wanted to leave you with well-being is your ability to do stuff. Work-life balance predicts future well-being, and if you measure it with psychometrically valid tools, we have a lot in our armamentarium that you can do about well-being, and we'll share some links with you in the chat and during the Q&A that you can use to address problems with burnout. So I'm going to go ahead and hand it over to Josh.
Thank you, Brian. As mentioned before, I'm with Safe and Reliable Healthcare, and we're the organization that gathered the SCORE data that we're looking at here across a number of different subsets of the data that we looked at in both pre and post views of the data with the COVID pandemic. We have been working for a long time. We have been in the healthcare space looking at culture data for more than 25 years and had an impact on more than 2,000 employees in the healthcare industry. We currently do the SCORE survey both in the U.S., Canada, extensively across England, and have most recently moved into Europe and have separate benchmarks for each of those areas. The SCORE survey itself, it's an integrated survey that puts together all of the views both in your culture, your patient safety, your engagement, and for those that are also doing Magnet, the Magnet bundle of your data as well too. We put this together a number of years ago based on some gaps in the prior survey instruments out there with both the ARC survey, the SAQ. There were certain areas like burnout that were not well covered. And with the SCORE survey, we've added both two domains that cover burnout. The burnout climate domain asks about the levels of burnout in the staff and the teams that you work on, and your personal burnout, so your own levels of burnout, as well as two additional domains that cover resilience, the emotional thriving and emotional recovery domains that were added in 2017. So with a single survey, as Brian mentioned, you can look across all of those areas in a psychometrically valid way with data and views that have been shown to correlate to actual clinical outcomes, patient experience, and other metrics that matter to you and your organization. The SCORE survey itself, when you're looking at the data, you can get insights to see where you have different areas that you stand out as an organization, where you have different cultural strengths, cultural opportunities, engagement strengths, engagement opportunities, and you can look across any of the questions and just see simply with a green, yellow, red, where do you have positive responses, neutral, and negative responses. And what you'll find as you're looking across your organization, that culture really does exist locally. This is a view from an example hospital, which is very typical across every single organization that we survey. That variance in the culture locally exists and really is spread across. And so if you really wanted to move your organization as a whole, you need to look at those departments and units that are scoring lower in the different domains, and you get very actionable insights into how you can move the meter and which questions that you can create action plans around to support that, and where you can support those local leaders. If we look broadly across our benchmark here, we're looking at more than 300,000 responses here gathered and put together in 2020, and you can see that the variance across that personal burnout, emotional exhaustion is quite wide across those 13,000 different departments. And then as you look and drill down the data even further, it's really important to look and see that the experience across your staff does vary. So here we're looking across about 35,000 respondents that we were able to track definitively pre and post. So we're accounting for any kind of variation in terms of who may have taken the survey 1 year, turnover in staff. These are the same 35,000 individuals taking the survey in both 2020 and in 2021. And you can see that their percent positives changed across the different race and ethnicity groups that they self-identified as. But what's really impactful is if you then turn that into the perspective of where do they stand out and what do they look like compared to the benchmark. So moving from percent positives to percentiles, you can actually see that the shift from these individuals, if these individuals existed as a hospital on their own in the benchmark, some of them moved from being in the 75th percentile all the way down to the 40th percentile just in the matter of 1 year across their personal burnout. Here we're looking at personal burnout percentiles, higher is better, and you can see across all of these different groups, their scores changed between 2021 and 2020. And then further, if you look across other demographics like gender, we can see those differences going from the 66th percentile to the 32nd for males, 53rd percentile to 21st in females between those two survey administration time periods. And then finally, if you look and see that the experience, as Brian mentioned, can be very different across both gender and race, you can see the variance that occurred for different groups. Here we're looking at both gender and race and ethnicity together across those 34,000 to 35,000 respondents. Similar experience for age group as well, changes that occurred overall, all of those dropped in terms of their percent positive percentiles, so their scores got worse in personal burnout by those different age groups. There was one group that we did see where we could definitively say, did these individuals shift their work habits? And we took a cut of approximately 5,000 individuals that moved from working from home working in the facility to working from home. And if you look at the difference across those that were working from home less than 50 hours at the end of the survey administration in 2021 versus those that were working from home more than 50 hours, you could see improvements across the board or no change, while those that did not have that shift to work from home saw drops in almost every domain with the exception of advancement. Interestingly, though, there was no shift in their work-life balance score for those that were working from home. So it's important to take a look at the data locally for your own group and then take that back to the staff and talk through that experience to make sure that you're understanding correctly and not just assuming that you understand what those shifts are. And with that, I'll pass it off to Dr. Frankel to talk about some of the other insights and ways that we can improve personal burnout.
Josh, thanks very much, and Brian, thank you, and Josh for shaping some of the data and giving me the opportunity to talk about some of the actions that we take to address burnout and high reliability. Just for folks to know, I'm the CEO of Safe and Reliable Care, an anesthesiologist by background, and been thinking about how do you improve the safety and reliability of care for patients, and how do you increase joy in work for those who deliver care, and I've been at that for a quarter of a century. The interesting piece about burnout, and I'm seeing it in the chat, is that the levels of stress and tension, the challenges that have arisen in organizations, all of you know, I'm not saying any great surprise, are just so much more intense now in U.S. hospitals. And the question is, how to go about managing that in a way that allows the organization to function? And is there a way of dealing with burnout that matches the kinds of activities that we've been asking organizations to do really for the last 20 years to achieve greater levels of safety and reliability? And in large part, the answer turns out to be, well, actually, much of the activity is one and the same. What I would say, and you can see it from Brian's data and his article about the WISER literature, is that there are personal reflections and the ability to kind of internally reflect as individuals that are increasingly important right now. The question is, what organizations need to be focusing on at this moment, both in response to COVID and understanding that COVID is going to be a prolonged issue for us? How do organizations get back to the work of increasing safety and reliability moving forward? So, interestingly enough, did COVID unify or separate us? I've heard lots of conversations about how COVID became a common enemy, allowing people who didn't always get along to focus on the work and actually get along better. Equally, and especially now, with this last set of challenges with the Delta variant coming in, people are just frankly exhausted and feeling as if the breakdown of community that I am hearing about in hospitals, nurses who are best friends for their entire lives in an emergency room who have suddenly stopped talking to each other because they're on different sides of the political perspective around COVID mandates. I mean, literally breaking down community within units, and community turns out to be one of the major factors in whether or not you can actually improve over time. That common phrase, the people around me care about me, is a critical statement that people have to make to engage in productive work in organizations. So when we talk about burnout, we really are talking about a multiple set of issues that are impacting frontline providers. Just prior to this call, I was speaking to the leadership of a hospital where, as we looked at their survey data, a big percentage, almost a quarter of the respondents had put in comments. In those comments, a good quarter of those were about COVID. Another quarter of them were about the perception that they weren't being dealt with fairly from a human resources standpoint in terms of pay scale or advancement or growth. And then another component of the survey results was, I don't feel that my manager gives me voice or agency, which is another key component of high reliability, that I can speak up and have a sense that I can influence my environment. The conversation we had was, you have to continue to talk about the COVID mandate. You have to deal with the issues relating to HR and the perception that you're not being treated fairly. And there are ways in which you can train managers to more effectively show empathy and interest in frontline providers. And the three of those taken together can help the leaders in this organization, I think, with some of the incredibly challenging times that they are currently dealing with. Looking at the data that comes from good survey administrations really puts you in a position as leaders to address and apply resources in a much more intelligent way and make some of the work less frustrating in the current environment that we're in. I'll just remind folks that the term burnout really has been explained most eloquently by Christina Maslach and used internationally, and that not just the symptoms of burnout, but the stages of burnout are important to understand. I come to work and it's frustrating that I can't get some of the stuff done. Well, I've been frustrated for so long I'm getting exhausted. Well, I'm not only exhausted, but there's no response from anyone, so I'm becoming cynical. Well, I'm past being cynical because I actually feel ineffective, exacerbated by COVID around the moral distress issues. And finally, I've gone so far down the path that I'm actually beginning to depersonalize in my interactions with other employees and workers and in the way that I see patients. The vast majority of burnout that we've been thinking and looking at over the last few years is in the world of frustration and emotional exhaustion. COVID has pushed us down to the next level, cynicism, and certainly the sense of being ineffective at multiple levels. And you ask, all right, so how do you go about addressing this? Well, when we run interventions at Safe and Reliable, and we are in the business of whole-scale, high-reliability transformation for organizations. We use our instrument SCORE as a baseline assessment. We set up academies for leadership coaching, middle management training, and frontline education and high-reliability concepts, and then vertically go into service lines in order to empower managers to be more effective in their units. When we look at the categories that cause frustration, exhaustion, cynicism, inefficacy, and depersonalization, we use our framework, which is similar to the Joint Commission framework, the National Patient Safety Foundation framework, and IHI's framework, in looking at four major components. What are the skills, the calendared activities, and the behaviors of leadership? What are the personal accountabilities, in other words, professionalism and just culture, the teamwork, the healthy environment, community, and the ability to navigate disagreements around consensus that make up culture? And then how do those foundationally allow you to create the learning system where you are collecting knowledge, the defects, the clinical, cultural, and operational defects in your system, and then knowing how to act on them using improvement methods as part of the learning process? We think about those, I think about those, when I look at culture survey data. The culture survey data informs me of where in this framework, in the circumplex, organizations need to focus. And the same applies when we look at and think about burnout. Leaders, by gaining skills, calendaring the rounding process, the huddling process, the safety forums, the participation in visual management, and behaving empathically and professionally when they're there, become the guardians of learning exemplars in their environment. That then sets the framework to create the community and agency of frontline folks and middle management to create the culture you need, which then allows you to collect the data that you turn into grist for the learning system that drives improvement. In order to deal with burnout, all of these have to be humming at the highest level in the current COVID environment. And the catch-22 is, I am so fried and so frazzled that it's hard to look at this and think about what actions to take and where. These are the fundamental truths about high reliability, but they are equally the fundamental truths about the causes of burnout. I could ask you, as you think of a time when you personally experienced these issues of frustration, exhaustion, cynicism, inefficacy, and then you think about the underlying reasons why, the likelihood is that you can package them into, how did my leaders act? What is my sense of agency or community culturally? In what way are people collecting the appropriate kind of data and becoming knowledgeable about it to act on it? And then how does my system respond and learn and change in order to deal with those insights? Burnout can be addressed, on the one hand, as Brian talked about very eloquently, by individual actions in which your perspective of the world changes as a result of activities that you participate in. And then in my world, it's how do you change the environment around individuals in such a way that we can begin to improve perceptions of frustration, exhaustion, cynicism, inefficacy, depersonalization, ultimately burnout when you paint the whole picture. There are a variety of ways of doing this. In the chat, there was a conversation about doing rounds. We know that doing rounds well improves the perception of everything and decreases burnout. Doing rounds badly makes everything worse. So can you round in a way that leave people feeling that they are valued, that they have a voice, that they are supported, and that they have the tools to do their job? Those 4 comments are echoes of Paul O'Neill's work in Alcoa, of the wonderful work that's being done in the VA healthcare system, our biggest healthcare system in the U.S., around the concepts of rounding, safety huddles, safety forums, and visual management. Done well by leaders supporting middle managers to do the same thing gets you safer and better care and improves perceptions of burnout along the way. And we see this in the interventions we run, and we see it in spades in the interventions we run, in some of, I think, the more cutting-edge activities that we're doing around the digital communication and visual management solutions that we're putting into organizations around the country. So you get together with your leadership in the morning who are burnt out, and you talk to them about what they feel. How do I feel? How do you feel around leading in an environment like this? What are the things I need to do? I have to create meaningful relationships. I do have to set a positive tone. I have to ask the right questions, appreciative inquiry, and think out loud and encourage the diverse opinions and acknowledge that not all of them are going to be taken up and acted on. I just had a conversation with a leader who said to me, look, we've decided we're mandating the vaccine. What do I do when people tell me that they don't want to do it and it's the wrong thing. And the answer is you go back repeatedly and have conversations with them about that issue, not necessarily saying you're going to change it, but saying, here's where we're going. I'm happy to talk to you about it as many times as you need me to in order for us to go down this path together around the areas where we do have common interest, which is patient care and supporting our employees together to find as much joy in work as possible. So the rules are simple. Be visible, listen, pause, be curious, message the mission, and ask the people's thoughts and ideas. And as painful as it is to get up every morning and lead in this current environment, these are essentially the things that you have to say to yourself as leaders when you brush your teeth going into organizations, that this is what I need to do. And as frontline folks to say, I know that this is what I expect of my leadership, and when I don't see it, I'll ask them for it. And I'll remind them of the importance of it, because together then we can take this journey that helps us improve. On the left-hand side, the image shows one of our digital communication and visual management boards. It's replacing these whiteboards on the left. We're now beginning to aggregate data across entire hospitals that then allow you to see frontline themes almost in real time as issues come up and improve the communication between senior leadership and the front line. There is no question that in 2021, if we want to grapple with the complexity of our systems, we need to begin using the appropriate technologies to support the way in which senior leadership, middle management, and frontline folks communicate with each other, and then use effective cultural survey instruments to monitor the changes that are occurring, and using the visual management boards, create new measures of engagement. Of 100 people in my unit, how many people are participating in putting in issues? How quickly do issues get resolved, and so forth? So while certainly visual management is not a panacea, used well, it is turning out to be extraordinarily effective, and we have preliminary data suggesting that the levels of burnout when this is done well are much lower in units in the same hospital, as opposed to whiteboards that are much clunkier and less effective for leadership to use, where we've seen actually burnout levels rise in the same institution. We'll have enough hospitals to publish on that sometime in the next year. So burnout reflections, the pitfalls, the concept of heroism, taking the right actions but the wrong communication. Classic one was a healthcare system that decided that in order to not let anyone go under the financial constraints of the initial COVID event, they were going to stop giving bonuses and stop giving pay raises. But the deal was no one would get fired. The problem is they didn't communicate it down to the front line. So the front line came back some number of months later and said, what is this? We're working harder and you're not giving us bonuses or pay raises. So they did the right action. We don't want to let anyone out of our community, but the wrong communication about what they were doing landed up angering their front line rather than bringing it down the path together. The leadership successes we've talked about. Visual management is daily work, measuring culture, showing up no matter what, and then managing effective bidirectional communication that is way more than you have to do, even more than you think you need to do in order to get the communication to be robust from a senior leadership level down to the front line. Leaders need to know what burnout is and understand it. They need to understand where it exists and why. It isn't just COVID. It's also the sense that you don't care about me because I don't get paid the same amount as everyone else in my geographic region. Well, that's what I believe to be the case. But no one goes in and actually does the data analysis to say whether that's true. And then to explore the causes. How effective is middle management trained to run learning systems? In our healthcare systems in general, not as well as they need to be. And then ultimately, if you peel 3 and 4 together, frontline folks have to have a sense of community and a sense of voice or agency, that when I speak up, I see change in my environment. Middle managers have to know how to do that well, and all of that ameliorates a lot of the frontline issues with burnout that we're currently seeing now. So let me stop there. An absolute privilege to be able to participate, Josh, with you and with Brian, and truly a privilege to be able to talk to all of you about a topic that is near and dear to my heart and so incredibly essential for our healthcare industry right now. Happy to answer questions and hear your comments with pleasure, and I'll hand it back to you folks in the AHA. Thank you. Chris?
Yes, thanks, Dr. Frankel and Dr. Sexton and Josh. I really appreciate what a absolutely great presentation, and I really appreciate also all the folks asking questions, sharing their email addresses, wanting to connect. You know, I feel like if I've learned anything from especially you, Brian, over the years, the importance of community and the importance of those good conversations, even if they're here and, you know, as they're growing this kind of global community of discourse, it has to be important for their well-being. So I love seeing this. This is a great chat.
It's important on levels, right, Chris? Important on levels.
Yeah. So let's see. So we've had a lot of discussion. A lot of the questions you guys have answered as speakers as we've gone along, but I think that we want to maybe touch base on some of them again to make sure people, you know, saw the big picture. Maybe they weren't all reading on the side while you guys were talking. There was a lot of discussion that kept coming up about support for the leader.
Yeah.
And you guys touched on it in the presentation orally as well, but I was wondering if you could dive in a little bit there because that's what a lot of the discussion was about. And I'm curious personally, you know, what could somebody like, you know, me do to support my leaders? You know, how do you look up? You know, I know there's that concept of managing up, right? Well, how do you kind of support up? How do you, you know, make sure because everybody's on the same team? So how do we make sure that everybody kind of has these same feelings of well-being?
So I'm happy to start, and I'd love to hear what Alan has to add to this also, because he's like the founding father of walk-arounds in the known universe. But we did something fun at the North Carolina Hospital Association a couple of years ago, where we surveyed every single president and CEO in every single North Carolina hospital through the hospital association. We looked at their burnout and we gave them an intervention for their well-being. And at first, we did this because hospital presidents and CEOs, they don't want to be participants in the study kind of necessarily with other staff that report to them, and they wanted to kind of be part of their own cohort. And so we kind of acquiesced and gave it to them. Let me tell you something. A couple of years ago, way before the pandemic, the burnout rate amongst CEOs and presidents in North Carolina hospitals was over 75%. That was before the pandemic. And so if you are a leader in healthcare right now and you're not burned out, you might very well be a sociopath because you have every reason in the universe to be burned out right now. This is the perfectly legitimate reason to kind of acknowledge that. So if you have the ability to feel sympathy and empathy for other human beings, for other carbon-based life forms, then you're probably pretty burned out right now, and that's normal. We have to start from that. And say that I think that's why some of the interest in Madeline's program has been so intense. Is like, what do we do for our leaders right now? We know that traditional safety rounding it needed a little oomph to kind of maintain the enthusiasm that they had once generated, and that was why we came up with positive walk-rounds. Positive walk-rounds are fantastic for that, but when you've got people spitting in the faces of healthcare workers and saying that COVID isn't real, that's a different kind of burnout. That's not just your run-of-the-mill average kind of burnout, and so that becomes a moral dilemma. You become really confused about what you're doing in your career and in your role, and do you want to? If you have the ability to think about working someplace else, you're often thinking those thoughts. That said, we need to make sure that not just changing the instructions for leaders from talking about risk to talking about what's going well while talking about risk to going full on to crisis rounding and emotional support rounding, where you're just saying, I'd like to check in, see how you're doing, and being physically present. So those are things that we need to be doing and modifying based on the reality at the front lines of healthcare delivery. But how we support those leaders, leaders aren't necessarily very good at asking for help, and they certainly don't want to be in parts of groups. I'm generalizing here, but in my experience, working with a lot of leaders across a lot of different institutions, they don't want to participate in the same interventions and studies and kind of task forces as non-leaders. And so having a forum, I think that's why this REST idea was so powerful. What do we do to kind of build up and support our leaders so that they can support everyone else? It's really important, and I'm hoping that by my rambling for a little while, I gave Dr. Frankel a chance to come up with something really super smart to say in response to this wonderful question.
Chris, I just want to point out that Brian is putting me up high enough on the pedestal that I can drop really far. Brian, and I started putting some of my comments into the chat. Literally, my heart breaks as I talk to groups of senior leaders who are currently in the environment that we are all talking about right now. And the thing is, you get to be in leadership positions in healthcare because, and very often you're a type A person, you're driven, you want to take action, you want to get the work done. Some people are more self-reflective than others, but this really is a time when you can come together and just say, pretty routinely, if you think about it, crisis command is bringing leadership together to manage a crisis. So operationally, the frequency of where you're having group meetings now suddenly goes up. The problem with COVID is that it's crisis command over an extended period of time. But if you continue to have those meetings, and in those meetings, you acknowledge the stresses with each other, then you have a community in your leadership that is supportive in its own right. And then the next piece after that is you begin to apply small-scale tests of change, the model for improvement, going to IHI's methodology of saying, what can we take away from what we're currently doing that even by 0.5% or 1% will make our day tomorrow easier than it was today? Well, good. Let's put it into action and test it and see what happens. And then you basically get up each morning and put your pants on one leg at a time because again, that's what we have to do. But go in and test the process to see, can I in some way or another relieve some of the burden, relieve some of the tension? And if you're doing that in a community of leadership, it makes this whole process more tolerable. I'd love to say that there were a more straightforward, a simple answer, more resources, the pandemic goes away, we're waiting for those. But in the midst of all of this, smart people can come up with ideas that can alleviate some of the stresses that separately you will not be able to do if you're not talking to each other about exactly these issues on pretty much a daily basis. So just some general thoughts, if those are helpful. The other piece I'd add to it is, and I've said it a few times, the need to be kind to each other at a leadership level has never been greater than at this moment. When you have differences of opinion, you want to resolve them collaboratively. All the classic Thomas Kilmann concepts around negotiation. When people make positional statements, ask yourself, what are the underlying reasons why they're making those? What are their underlying interests? Point out when positional statements get made, why? What are you thinking? Explain it to me so I understand. You want to run your negotiations, if you think avoid, accommodate, compete, compromise, collaborate. You want to manage all your negotiations in ways that lead them to be collaborative and therefore maintain the relationships that you have with each other. So when things become competitive, you want to stop and say, all right, let me just reflect on what we're doing here. How do we change the tenor of this conversation? There are ways of easing the leadership process that we're in right now. They're small, but they can make a big difference.
Thank you. That was
that physical presence is so important too. Hiding in your office right now is a really bad idea for leaders of all levels. We need to be out there and be seen. It's so important right now.
Yeah. Well, and Brian, I'd add, look, I run a company of people who are spread across the United States. I'm in a position where the only kind of rounding I can do is virtual rounding. Is it challenging? Yes. Is it feasible to do? The answer is yes. especially in this day. I mean, COVID has taught us we can, on video, actually create reasonable relationships with each other. And I'm not saying that replaces being there physically, but there are some places where virtual rounds can really make a difference if you structure them effectively and then engage in them.
Feeling seen, feeling heard. It's the start. It's a really good starting place. I know we're at the end of our time. I just want to say thank you all for being a part and for your aggressive participation in the chat has been really inspirational to us here today.
Yeah, thanks everybody. To all three of our speakers, thank you so much for doing all the great work you're doing. We're really looking forward to hopefully seeing you when the conference gets rescheduled, because this is amazing, and the great possibility to have some of these conversations live and to really dig in is just it's really exciting to me. So everybody, just want to thank you all for attending today. The final reminders on the screen right now, just that if you're looking for that continuing education information, make sure you create that Duke OneLink account and then text the code on the screen to the number on the screen within 24 hours. So that is what you need to do to get that. We love seeing your evaluations. People always have great ideas, so please send that on to us as well so that we can always improve. Stay in touch. If you have any AHA team training related questions, shoot us a message, give us a phone call. We're here for you, and we're happy to connect you as well with, I'm sure today's speakers would love to hear from you in the future. So without further ado, thank you all and have a lovely rest of your day.
Thank you, ladies and gentlemen. This concludes today's presentation. You may now disconnect.